My name is Pedro, and I'm a clinical physiologist doing intraoperative monitoring for the last 12, 13 years. And today, thank you for Space Medica to ask for my opinion and my experience using the Cerebro strip electrodes. So I'm going to talk about how to use it, kind of the best uh, advantages of using this particular electrode in several procedures, mainly for brain and brain mapping and also visual evoked potentials that can also be used. So the first thing I want to talk about is the design. So have you ever used strip electrodes before? Yeah.
Yes.
So one of the things that I noticed on previous electrode is the contact is a disc that it's embedded on that silicon. This one, it's much flatter and it's printed. So in terms of um, thickness, it's much better when you have to consider the brain. And one of the things, if you have experience with these, it's the level of movement that happens inside the brain after introducing the strip. So having a flatter or slightly thinner strip, you get a lot of advantages. So it doesn't move as much, and it can be adapted to the curvatures of the brain. And being thanks to that the multi-layer print technique, it's like it's the position of those materials, normally platinum, that you get that advantages. So it's not stainless steel. It also means it can be in the brain for a little bit longer than the stainless steel. One of the things that I like in terms of the design is very well labeled, so you can clearly see the numbers. They're not small, they're not too big, so you can actually see where they are. It has a nice gray box that you can attach to the drapes, so it stays nicely and secure. And as you can see, the cables are also nicely color coded, and the numbers at the bottom, you can see them. Most of the other electrodes that I've seen, you couldn't see them very well. I'll show you some examples later. So can you see that the number is very faint, so you can't even see where the number is? And imagine being under the drapes, trying to find out which contact is number 1 or number 3, and you mix them around. It's a disaster. So I think Spaz is doing a great job, good label, and clearly, like visually, there's different colors, so you can't get it wrong, or you need to try really hard to get it wrong because it's difficult. And another thing is they are very well secured, so when you pull the touch strip connector, this doesn't happen. So for a design point of view, it's very good. And as I mentioned before, the way the other discs are embedded on that silicon make this slightly more rigid than the Space Medica one. So in terms of quality, thumbs up, well done, Space. And my as soon as I start using it, I notice immediately the advantages of having the strips. Another thing that was more evident with the previous strips, and I never seen it with the Space Medica one, is when the strip is placed and we do continuous motor potentials directly on the cortex. This phenomena was happening, and I never seen it happening with these ones. So this is like there's like a burn in the brain, and that's caused by the tissue damage when current is applied. So we are applying current through all these small contacts, as you can see, and that current, by penetrating, touching the brain, can cause a small burn, and then you can see that the coloration of the cortex is, it happens because there's a strip on top of that. So I can't explain, how the Spaz managed to do that, but I never had an incident like that in the past. So it's a very important thing to address. If you can't see, I think there's one strip still there. Most of the times the strip is under the dura, so you can't see it. But I really stress, if you have an option or to actually see under and to see if everything is clear, see if you can document these things, because they happen. No one is talking about this yet. So if we can collect more data about this phenomena, we can build some more information. In terms of applications, the most of them will be for stimulation. I will start with electrocorticography. They work really well. So this is a case where we recorded with two contact strips placed in different locations, one on the right frontal lobe and one on the right temporal lobe as active recording. And this is all reference to FZ. And obviously on this one, you didn't use propofol, use sevoflurane. Now it's changing. I think propofol would most of the times attenuate the spikes. So we used sevoflurane on this instance, and it was a better way to record some of the activities. As you can see, the control one and the active recording one in the referential mode or differential, and you can clearly see the areas that were giving us these paroxystic events. So it works really well for recording this. So for even epilepsy surgery, it's a very good tool. So more, this is it's a baseline pre-resection. Obviously, just to give you an example of what it can do. For phase reversal, are you aware what phase reversal is in intraoperative monitoring? Probably no. If you don't, I'll give you like a quick discussion what we do. So for the upper limbs, these are the normal references that we use and the derivations for upper limb and lower limb stimulation. So what we need to take on this one is if a strip electrode is placed, for example, on the right-hand side, we need to stimulate the contralateral limb and record an N20 in the brain. The strip will give us that kind of response where we place it if it's near the somatosensory cortex. So what we achieve with the strip is, to try to identify pre-central from the post-central gyrus and see the responses, the N20s, which will be post-central, and the P22s, which will be the pre-central areas. So this is a classic example how to get a phase reversal. I don't need to be very thorough on this. I just want to show you that at least the strip needs to be on the central sulcus. If it's not there, it's not possible to record. And the phenomenon is this dipole effect that happens is these afferent responses from going from thalamus to the cortex will change the potential crossing the central sulcus when they are recorded on the pre-central gyrus. So there's a change on that phase. So instead of the classic N20, you see that the phase reversal phenomenon. So that's how you can differentiate where the central sulcus is. This is the classic response when you see the phase reversal occurring intraoperatively, and it's right there. So channel 1 and channel 2 will be the one separating the central sulcus. That will be right here. This is post-central, this is pre-central. As you can see, the rest of them on the pre-central gyrus most likely activate or getting responsive from motor cortex. So the other application is going to be for cortical MEPs. For that, and very quickly, we need to have a patient not paralyzed. So trainer 4, it's important. And then for that, I recommend short-acting muscle relaxants, and we need to see the four twitches before attempting a motor evoked potential. Otherwise, it wouldn't work. And these are ways that we can stimulate. So just a little bit of quick explanation. If we use a strip directly over motor cortex or a transcranial stimulation, either interhemispheric or hemispheric stimulation, it's the case of the strip, and the different locations of the electrodes that will give us either better responses for the legs or the arms and legs. So just to give you an idea of the optimization of MEPs, usually we have normally 5 pulses with a repetition rate of 500 hertz or 250, depending on how do you want to get the best responses. A pulse width of 0.5, polarity depends how you want to get the responses, monophasic or biphasic, and the current intensities. You see that you need to achieve a threshold to start getting motor evoked potential. So anything between 80 and 90, you start getting some responses depending on sedation. So this is just a little optimization process for cortical MEPs. Obviously, anesthesia is very important. Propofol and Remi should be the gold standard, and a bite block. So just going again on the stimulation parameters for the strip. So you need to use a train of 5, so 5 pulses. The pulse width could be anything from 0.2 to 0.5. Maximum intensity, I stress 25. Most people might seem too much, but for areas like face and legs, at times I need to go even higher to 30 at least once to exclude those areas. So this is a good way of checking with a strip electrode areas of the face, as you can see here, mentalis and tongue in one of the channels of the strip. And then if we start moving the channels, so 2, 3, or 4, we can start getting the arms and the hands with the strip. So we have a good way of monitor the integrity of the corticospinal tracts from the point of stimulation. So this is the beauty of having a strip electrode all the time in the brain prior to the tumor resection, because that will give us I call it like the holy grail, is the integrity of the pathway. It's using a strip electrode. So it's a good method to do the monitoring of the corticospinal tracts. So we can do that with or without phase reversal. I normally recommend, because you can check the impedance of the strip, right from the get-go, and you actually can, how close you are from the central sulcus. So phase reversal for me, it's really nice. If you don't have time, go straight to cortical stimulation. But I'll suggest give it a go first, because if you don't connect the electrode on the right channel, you don't know if the strip is in good position. Or, and you'll laugh, but it happens, the surgeon places the strip upside down, so the contacts look facing up. So you stimulate, nothing happens. So if you don't do an impedance check, you don't know. So you waste like 10 minutes trying to stimulate and nothing happens. And a good way of cortical stimulation with a strip, in comparison with a Penfield technique, is seizure avoidance as well. So you can also stimulate other areas like the supplementary motor area and know exactly where we are. So that I was talking with the strip. I was talking about the monitoring. We also need to do dynamic mapping, which is with a probe. So somewhere that we touch the brain and we know exactly where we are. So we can do that either before or after the strip, and know on the motor homunculus the areas that we are stimulating. So for that, you use that suction probe. I'm not sure if you have one here, but you might have that one. That's it. That's it. So when we use the suction probe, so we can do that kind of dynamic mapping. We can map it at the surface of the cortex, but it's most importantly for the subcortical stimulation. There we go. Thank you so much. So when the surgeon is resecting the tumor, and we know that the strip is stable, he's going to look for the corticospinal tracts near the tumor. And as soon as you get closer, depending on the stimulation, we use this rule of thumb is 1 millimeter, 1 milliamp. We can guide them to say how far they are from the corticospinal tracts. So it's a very important tool to do some sort of dynamic mapping of the brain and aim for maximal resection. So you can see this is already at 6 milliamps. So it's very close. So then as soon as you drop the stimulation, you get even closer to the corticospinal tracts. And usually we stop at 3 to 4 milliamps. So if you get responses below 3, you are too close to the corticospinal tracts, and the chances of introducing a new deficit are much, much higher. Another very good application of the strip is for visual evoked potentials. So the normal way that we have for visual evoked potentials is using corkscrews at the occipital, on the occipital region, but if we slide a strip electrode on the occipital lobe, it's much easier because the impedances are much better, and you have far better potentials on the visual evoked potentials. For that, I normally use a combination of the VEP goggles, which are disposable. You have some over there. It's much easier to use than the traditional, chunky goggles. So those are disposable. They are flexible. The profile is much, smaller than the traditional ones. And in combination with the ERG electrode, it might be there or not, but essentially a thread that we use in clinic for VEPs. We can also use it intraoperatively to record the initial ERG response. So to put it in context, this is the best way to find the threshold for the stimulation and also confirming light is going to the retina. So a very good tool to use a combination of the strip electrode and the goggles for stimulation. You get much better VEPs using these techniques. For other applications, again, subcortical recordings, they work really well, especially the ones that I mentioned at the beginning, the recordings from the cavity. Is very good to do cortical evoked potentials. I'm not sure if this is a novelty for you. We've been using it now slightly more regularly, especially with the different arrays that we have. So the 2x4s or even the grid arrays that we have. Anything that we can do to maximize contacts, and it's very good for the cortical evoked potentials, and getting very good results with that too. And I think, I managed to cover in this short period of time uh, all the advantages of the strip electrodes and the best techniques